Good afternoon, everyone. It is my pleasure to introduce our next presenter, Cynthia Kanaki. Cynthia is a registered respiratory therapist since 1979 and is director of chapter care services with the ALS Association. She provides guidance to the ALS Association chapters and clinic staff nationwide related to best practices in ALS program care and services. She is an active participant in patient and professional education regarding ALS, including clinical options available to decrease work of breathing, maintain airway clearance, prolong survival, and maximize quality of life. Cynthia, we're thrilled to have you, and we're looking forward to hearing your topic on respiratory challenges and care options in ALS.
Thank you, Marit. I appreciate the invitation to share this information with you today, and particularly appreciate those who are carving time out of their afternoon to join us. Many of the folks that are joining us are probably already familiar to a greater or lesser extent with the respiratory challenges that are associated with ALS. This afternoon, we're going to take an opportunity to review those challenges and some of the potential solutions that may support people during their journey with ALS. My slides are up on the screen, so we'll just move forward from there. I do have some disclosures. I do have a very minor financial interest in some of the following companies, but if I mention a brand name, it is certainly not an endorsement of a product or service. Let's focus on these things this afternoon: respiratory challenges and some potential options in ALS. We really want to identify those challenges specifically so that we can match some potential options to them. Always looking at decreasing the work of breathing, maintaining a clear airway, and both of these things actually lead to maximizing quality of life. Let's look at the symptom onset. Again, many of you are already familiar with this. Limb onset is the most familiar onset, and again, the weakness generally starts in the arms or the legs. The bulbar onset that impacts some people typically impacts those folks with their swallowing and speaking. But there are a subset of people that have a respiratory onset. It's a relatively low number of people, maybe 10% or so, whose initial symptoms really begin with their respiratory system. That said, even those that have a limb onset or a bulbar onset will eventually experience symptoms associated with their respiratory system because ALS will impact that. How is that impact? Really, it's the weakened muscles. The respiratory system themselves, the lungs, continue to work as they were intended, unless someone has a comorbidity, for example, emphysema, COPD, bronchitis, severe asthma. The lungs are going to work as they typically have in the past. The issue is those weakened muscles really inhibit a person's ability to take an adequate breath. You may have been used to taking in a quart of air every time you take a breath in and out. After so many months with ALS, your muscles have weakened and now you're only able to breathe in a pint of air. As your journey continues, that volume tends to decrease, and therein lies the challenge with breathing in adequate volume. Again, those are all due to the weakened muscles, the diaphragm, intercostal muscles, and other muscles associated with breathing. In addition to that, and something we don't often think about, is our ability to clear our airway. People cough frequently during the day without even thinking about it. Most of us are on autopilot to cough, whether it's just to clear our throat, clear our airway, or if there's something in our airway that is irritating. Unfortunately, being able to have a productive or effective cough really relies on your muscles and your ability to take a deep breath. And we'll look at that in a few minutes. Every single respiratory therapist, pulmonary physician, and ultimately your neurologist, when you were talking about your respiratory system, really has one goal in mind, and that is to decrease your work of breathing. By now, you know that ALS is a disease that really increases your expenditure of energy. So what we want to do is we want to decrease that work of breathing so that you use less energy to take in the adequate breaths that you need and to be able to cough effectively. I want to take just a minute to review the difference between respiration and ventilation. Sometimes these terms are confused. We often think about our respiratory rate, how many times a minute we breathe, or we refer to things as our respiratory issues. Respiration actually means gas moving across a membrane. So when we take a breath in, the air comes into our mouth and goes into the lungs and then crosses the membrane to get into our capillary system. That's the first part of respiration. The gas is crossing a membrane to get into our bloodstream. That oxygen then travels through our body down to our big toe, and now it's at our big toe, and that oxygen is leaving the capillary system and going into the cells. Internal respiration. So respiration actually means gas moving across a membrane. Ventilation, on the other hand, really refers to gas moving out of things. When we roll the windows down in our car to increase ventilation, we're moving air in and out of the car. When we open up our glass sliding doors on our porch, we're opening that up so that we can increase ventilation or get that air moving from inside the house to outside the house. When we are talking about ALS, we're really going to focus now on ventilation, because what's important is being able to take a breath and get an adequate amount of air into your lungs and then breathe out, in addition to being able to coughing effectively external. You can see here the muscles that are affected with ventilation. The diaphragm is your major muscle of ventilation because that's the main muscle we use and the most effective muscle we use to take in a deep breath or even to expel our air. The intercostal muscles, those muscles between our ribs, are also very helpful. Those are secondary respiratory muscles. And then even those muscles that go from the top of our clavicle up through our neck into the sternocleidomastoid muscles are also muscles that enable us to increase our ventilation. Again, that's the challenge in ALS. These muscles become weak and we're unable to move the same volume of air. When people go to an ALS clinic, a respiratory evaluation is typically included in that clinic visit day. We're measuring ventilation because we want to be able to monitor, again, how much air you're moving in and out, because that's an indication of how weak those respiratory or ventilation muscles might be. There are several images here on the screen. You can see the image in the upper right-hand corner is showing a piece of equipment that's used. It's this electronic spirometer that measures how much air you're moving in and out, and also how quickly that air is going in and out. And you can see this gentleman here is doing a maneuver known as a forced vital capacity. So he takes in as deep a breath as he can, and then he blows out as hard and as fast as he can, so we can measure the volume of air and also the speed with which that air is coming out. The FVC is noted in your medical record on every clinic visit, and it's really important because we want to monitor over time what that value is. That gives us a really good idea on your muscle strength and how that is trending. Other tests that can be used are the PaCO2, which is an arterial blood test that measures how much carbon dioxide is in your arteries. That's an indication of the how effective your ventilation is. As your ventilation becomes less effective, your PaCO2 levels will go up. As you increase ventilation, the PaCO2 levels typically go down. Another test that many people use in clinic is called the MIP, or the MIP, maximal inspiratory pressure. And you can see here that it has a negative in front of that. That's because we're measuring a negative pressure. This person will be asked to put their mouth around or use a mask and then breathe in as hard as they can. They begin breathing in, and then all of a sudden their air is occluded. So they're essentially sucking in air against a barrier, so we can measure the force with which they're able to suck air in. And again, that's very important because when you think about it, when you take in a deep breath, especially if there's an occlusion. We want to be able to measure the strength of the muscles you're using to do that. I put a notation on this screen, sitting versus supine. Some of you may be familiar with that. You know, it's much easier to breathe in and out when we're sitting up than it is laying down. And I think that's common for everyone, not even people living with ALS. When you think about it, when you're sitting up, you have gravity working for you. All your abdominal contents are below your diaphragm, your thorax or your chest cavity is up, your shoulders are up, your arms are down by your side. So it's a little bit easier for your diaphragm to lower and your intercostal muscles to expand for you to get a deep breath. If you were to lie down or recline in the supine position, gravity's no longer your friend. Your diaphragm is going to have to push those abdominal contents sideways in order to make room for air to come into your lungs. Your thorax's muscles are not going to be as effective. So oftentimes clinics will ask you to measure your ventilation in a sitting position and then also ask you to lay down or maybe recline in your wheelchair to the supine position, because we want to make sure we're measuring how much energy your muscles are using in both positions. Interestingly, most people do sleep in the supine position. You know, we lay down when we go to sleep, and we want to make sure that we're able to monitor your ventilation status, not only while you're sitting, but when you lay down as well. So that's important. Some of the potential solutions to support ventilation when during the course of the disease, it's noted that you are having issues with ventilation or you're not ventilating enough, are invasive and non-invasive respiratory support. And again, ventilation support. You see here, our ventilation again is just simply air going into the lungs, diaphragm goes down, and then on exhalation, it returns out. So this is really function of your muscles and the strength of your muscles. Invasive ventilatory support provides respiratory support or ventilatory support with the use of a mask. It could be a nasal mask, it could be a mask that goes over both your nose and your mouth, often termed BiPAP or bi-level non-invasive support. You can see this gentleman is using that. He's actually using it portable with his wheelchair. So he's able to receive non-invasive ventilatory support, and he's even out in the community doing that. Another method to provide respiratory or ventilatory support is invasive ventilation. That involves the use of a tracheostomy. In this case, an opening is made into the trachea or the front of your throat here, and then the equipment is connected directly to your throat so that the ventilator can provide air into and out of your lungs directly through your throat this way. And you can see the image here of a gentleman. He is in a power wheelchair. It's difficult to see. His portable ventilator is on the back of that wheelchair. You can see the tube here going to his neck. So he's using invasive ventilation or tracheostomy ventilation. And you can see here he has his computer and communication device there. Both of these are available. Most people with ALS will certainly consider the use of non-invasive support. You can use this part-time. You can actually use both of them part-time. Oftentimes folks start using non-invasive support during nighttime when they have a greater need for respiratory support. And then as the disease progresses, they can utilize this during the day as well. The same thing for invasive ventilation. I do want to note, though, that while the use of ventilation does support adequate ventilation, and it can extend your journey with ALS, it does not stop the progression of the disease. So even though you use ventilation support, it will not stop those respiratory or other muscles from continuing to become weaker. This slide has several images of different types of equipment that people commonly use. Again, these brands, there are several brands available in the community and marketplace. The bi-level or BiPAP support typically provides support for people that begin using respiratory support at night to assist them. This really helps in getting a good night's sleep and enabling you to wake up refreshed in the morning. The portable ventilators, all of these are literally the size of a woman's pocketbook these days, and most of them have battery backup, so you are able to take them on the back of your wheelchair into the community. Ventilators are also available that provide non-invasive ventilation. These ventilators are designed as life support pieces of equipment, and they're designed to provide mask ventilation, mouthpiece ventilation, non-invasive ventilation, or tracheostomy ventilation. And there you see images of several pieces of equipment that are available. Let's talk about some of that non-invasive ventilation. The mask or the interface is really important, and size does matter. We all come in different shapes and sizes, but it's really important to have the appropriate size mask, and there's a variety of masks on in the marketplace. And I know you had shared some information earlier with folks with your DME companies and home care companies that really have expertise in assisting with identifying the mask that would be most helpful for you. They are nasal masks that cover just your nose, full face masks that may cover your nose and your mouth, or hybrid masks that cover your mouth, but then also have what are called nasal pillows to provide support into your nose. This is fabulous because you can still put your eyeglasses on and read the paper or watch the evening news while you're taking advantage of non-invasive or bi-level support. Sometimes people use one mask at night and then they use a different mask during the daytime. And it's not uncommon for people to have to change the mask that they're using because as they lose weight, they may have to access a different type mask. Again, there's more. Oftentimes, as people's journey progresses, they desire respiratory support during the daytime. We know we get up in the morning and we're rested because we've had some respiratory support at night, but by the time we go through our morning routine and have a meal, we're becoming fairly fatigued. We can take advantage of ventilation support during the daytime hours without having to put that mask on. These two people are using what's called mouthpiece ventilation. You can see this gentleman here in his wheelchair. This is connected, and it's simply a mouthpiece that he can put his lips around. When he does that, the ventilator is set up to provide him with a puff of air or a breath of air. He may need 2 or 3 breaths every 5 minutes. This person utilizing the same setup may only need to take a few breaths every 20 minutes or every hour. What's valuable here is for you to know that these potential solutions are available if it fits your particular situation. So you can use a mask at night, and then you can utilize a mouthpiece during the day to support your ventilation as the day wears on. You can see here with regard to invasive ventilation, people have questions about the quality of life. There's a big difference between putting a mask on that takes just a few minutes to put on or take off every day versus people contemplating having a surgical procedure to put a tracheostomy into their neck. I want to share with you again information so that you can review potential solutions that may or may not be appropriate for your situation or your family or faith or finances. But when you consider the quality of life for people that are using invasive ventilation, I wanted to share with you that there are some features of invasive ventilation. For people that cannot control their upper airway, people that have severe bulbar issues, that they're not able to open and close their throat or their airway properly without the risk of aspiration, a tracheostomy may be indicated so that we avoid the risk of aspiration and pulling things down into our lungs. Those people with refractory sialorrhea, or that just incredible ongoing secretions, become an issue. Or for people that are unable to maintain adequate ventilation using non-invasive ventilation. You can see these are 2 people with ALS. This gentleman actually lives in a nursing home, and he was able to go out and see a baseball game, taking along his pocketbook-sized ventilator with him. So again, still able to enjoy some quality of life and participate in things that are important to him, even though he has a tracheostomy. You can see this other gentleman is at home, and of course he has a tracheostomy here, and he's utilizing an eye gaze system with his wife to communicate. So again, just want to share with you that most people begin their journey with respiratory support utilizing non-invasive ventilation, a mask or mask and mouthpiece. And some people choose to move on to invasive ventilation if that's indicated for their situation and it will work for their family. Some of the advantages of invasive ventilation are that it certainly does improve your oxygen levels and carbon dioxide levels. It absolutely decreases your work of breathing because the ventilator, the machine, is doing more and more of that for you, especially if you get to the point where your respiratory muscles become so weak you're unable to take in an appropriate amount of air on your own. It improves your sleep quality. In general, it improves the quality of life for people that choose invasive ventilation. Some of the disadvantages, of course, complications of long-term dependence on artificial airway and life support. The cost of the care. Medicare will pay for equipment and supplies, but Medicare will not pay for someone to provide 24-hour care for someone who has a tracheostomy. And then again, quality of life. We saw here that an advantage was it improves quality of life for people that have a tracheostomy, but some research shows that the quality of life for the primary caregivers does not go up as much as the quality of life for the people that actually have the tracheostomy. And here again, you can see two different scenarios of people that have a tracheostomy out in the community and then again at home. What's really important, regardless of the type of support that you decide to move forward with, is monitoring your respiratory status. Once you move forward with utilizing non-invasive ventilation, your home care company will set that equipment up for you and visit you periodically to make sure the equipment is working okay, to download some of the information on the machine that shows them how they can change the settings on the machine to what? Our goal we mentioned earlier was to decrease your work of breathing. As ALS progresses, different muscles become weaker, and we want to make sure that we're adjusting that equipment to continue to decrease your work of breathing. It's important for that home care company and the respiratory therapist to visit you to download that information and to make those adjustments. It may be an adjustment to the machine. It may be a different mask. It may be one mask at night and a different mask that you're using during the day. Very important for the clinic and that home care company to communicate with each other. We see that it's imperative that that data is downloaded and reviewed and shared with your clinic team. Airway clearance, we talked about ventilation, making sure we can get air in and out of the lungs, but we haven't yet spoken about airway clearance and coughing, and that really is essential. Again, we're on autopilot for coughing. We cough so many times during the day without even thinking about it. Some of the things we have to protect our airway from are aspirating those secretions that tend to build up, especially if our muscles are weak in our mouth or our throat and we're not able to swallow those effectively, or aspirating food and liquid. I do a quick circle around here. How many times have we thought, oh my goodness, that went down the wrong pipe? We don't want food or liquids to go down the wrong pipe because that will potentially set us up for pneumonias or other issues. If you have just a minute here, let's just experiment with coughing. I'm going to ask everyone to cough. So I'm going to give you 3 seconds, and please go ahead through the process of coughing. As many of you may experience, when we hear the word cough, we oftentimes think of a noise or something coming out of someone's mouth. But the reality is the first part of taking a cough is actually taking a deep breath. And therein lies the challenge for many people with ALS. If we're not able to take in a deep breath, it's going to be very difficult for us then to use our expiratory muscles to force what little air we brought into our lungs out. And that's why people with ALS oftentimes clear their throat, but are not able to have an effective cough. Again, very important. And your clinic team is monitoring this when they ask you to measure your peak airway flow. So this is another simple device with a mask or with a mouthpiece that measures really how fast you're able to cough out. And you can see that 270 liters per minute, that's quite fast. If our ability to blow out or clear our airway, peak cough flow, is less than 270 liters per minute, we're really at increased risk for aspirating or not being able to clear our own secretions effectively. If it is lower than 160 liters per minute, that really is an indication for a prescription to help us with airway clearance. These are some of the pieces of equipment that are associated with airway clearance. Some of the equipment is really very low-cost equipment that many people can get from their clinic team. This is a bag mask valve. The person in the middle, you can see here, he's actually doing this himself, where he has a mouthpiece in his mouth, and he's using his arm to squeeze this bag that's putting air into his lungs. He can squeeze this bag, and he can take a breath, hold it, another breath, hold it, a third breath, hold it, so he can get essentially a triple volume breath before he blows out. That's one way to increase your ventilation and increase the volume of air in your lungs before you blow out, because of course the volume of air is going to be associated with how effective that cough is. And you can see here the idea of the cough is to move all of these things that are in your lower lungs up into the trachea so that you can cough and spit them out or swallow them if you're able to swallow effectively. In addition to some of the very low-cost pieces of equipment you can get from your clinic, or other pieces of equipment you can get through your DME company by prescription. These are two examples of two different companies. These are mechanical insufflator, exsufflators, or cough assistance equipment. These pieces of equipment essentially act as a combination hair dryer vacuum cleaner. So on inspiration, they act as a hair dryer. They're going to blow a good volume of air into your lungs. And then on exhalation, they're actually going to utilize negative pressure to help pull those secretions out. Oftentimes, these pieces of equipment are displayed when you're at your clinic visit, and your physician may write a prescription for that to be delivered by your DME or home care company. Sometimes secretions are a real issue for people with ALS. You know, our body generates so many secretions during the day, we don't even think about it. Again, we cough on autopilot, we swallow frequently during the day without ever thinking about it. Some of the things that can be done to manage those secretions, variety of ways. Medications can be prescribed that can literally decrease the amount of secretions that our body is making. Another method is to actually provide radiation to the glands that secrete our saliva. Again, these are more extensive solutions for people that are having severe or more serious issues associated with their secretions. In addition to electron beam therapy, they're actually utilizing the botulinum toxin to inject that into the salivary glands so that they stop secreting the same amount of secretions and decrease that for you. Another potential solution, and this does seem like it's a very bizarre solution, is a total laryngectomy. And I put this up here and noted the reference. For some people with ALS, some folks with ALS have severe bulbar symptoms whereby they're unable to speak, they have significant sialuria or secretions, and it's really a huge problem for them because while they're unable to speak, these huge amount of secretions are causing a potential aspiration risk because we don't want those secretions to go down into the lungs and cause a pneumonia. Some of the folks with these severe bulbar symptoms may not have severe limb symptoms. They can be walking around and still have an issue with an inability to speak or swallow or maintain these secretions. For those folks, a potential solution may be a total laryngectomy whereby they remove the voice box, the larynx, and then they just pull the trachea right out to the front of the neck. This way, the person is able to breathe in and out. They're able to utilize their diaphragm, their respiratory muscles to breathe in and out, but they really address this potential aspiration risk because nothing they put in their nose or their mouth will go into the trachea. Everything will go directly into their stomach. So again, it seems like an outlandish solution, but I wanted to share with you that there are a wide range of potential solutions. So be sure to talk to your clinic team regarding these solutions. Let's look at some of the other challenges associated with ALS. I know that this presentation is really focused on the respiratory challenges, but I wanted to share with you that some of the other challenges associated with ALS, like mobility, communication, and nutrition, also impact or overlap the challenges associated with ventilation. Let's look here, your power wheelchair. We know that it's very important to be in a proper seating position. I met someone in an ALS clinic whose wife shared, my husband really needs to see the respiratory therapist. You know, he's so short of breath. And he was sitting in a little transport wheelchair with a sling bottom. He didn't have any support for his feet and he didn't have any place to put his arms. So I wasn't surprised that he was having some respiratory difficulty. But I shared with them, the physical therapist is right outside. Let's chat with them and see what we can do about an appropriate seating so that once someone is in an appropriate wheelchair with support for their torso, with some support for their arms and support for their feet, it opens up their thorax and it makes it easier for them to breathe. So the respiratory therapist certainly did see them later that day, but they got immediate relief simply by moving from that little transport wheelchair into a different wheelchair that provided appropriate seating, support for their torso, support for their arms. So it opened up their chest cavity, decreasing their work of breathing without ever having to see the respiratory therapist. Another scenario is nutrition. You know, as the disease progresses, the time to dine seems to increase in length. What used to be a dinner that could be completed in 20 minutes is now 30 minutes or 40 minutes or 50 minutes because it takes so much energy to eat and because you want to be careful when you're eating and swallowing that it doesn't go down the wrong pipe. Perhaps it's time to talk to the dietitian or the speech therapist or the physician about how a feeding tube may be beneficial. If you can get the majority of your nutrition in through the feeding tube, then you're not expending so much energy during your mealtime, and that will also reserve that amount of energy for you to breathe. Remember, the longer it takes you to eat, the more energy you spend on eating, the more energy you're going to have to spend on taking those adequate breaths. The same thing with communication. You know, as our ventilation decreases, typically the volume of our speaking decreases because we don't have big volume of air. We can speak and project our voice out, but as our voice becomes weaker and smaller, we have to take a deeper breath. The point here is to utilize the different communication tools and equipment that are available for us so that we can, again, maximize the efficiency of the energy we're expending, whether it's in our mobility, in our nutrition, or even in our communication, so that we can decrease the work of breathing. You can see here, someone is utilizing that nasal equipment during the day. I know that you've seen a lot of this equipment. I know that the Symposium has available to you an expo section so that you can visit different DME companies or home care companies and look at some of the equipment or tools that might be available to you and be potential solutions for you. Let's look again at that seating. This exact scenario I shared with you earlier, where certainly this transport wheelchair may be effective if you're just moving from your doorstep into your car, but if you're spending any amount of time in a wheelchair, it would behoove you, both with regard to mobility and your respiratory support, for you to be in proper seating. The same thing with communication we mentioned. A lower tidal volume, or that lower breath that you're able to take, often results in a lower volume. So take advantage of the low-tech or high-tech communication devices that might be available so that you can communicate effectively and save some of your energy for your ventilation. Nutrition as well. That's one of the reasons that your clinic team is so frequently measuring your vital capacity, or the amount of air you're able to breathe in and out, is because as that decreases, and it typically does as the disease progresses, we don't know what the timing of that is, but we certainly do anticipate it's going to decrease. That's why it's so important to monitor that. We want to monitor that along with your other muscle strength, because as we look at your ability to maintain adequate nutrition, your nutrition is going to provide the energy you need to support those muscles so that you can continue to eat, or that you can continue to take those adequate breaths. There comes a time when it's more risky to go ahead and move forward with putting that feeding tube in if your ventilation status becomes very, very low. So again, let's look at not just how your ability to take in a deep breath or your ability to cough effectively. Let's look at how you're using your mobility equipment, your communication equipment, and certainly your nutrition equipment and options in order to support your quality of life and decrease your work of breathing. I think the partnership with your home care DME company is really critical. We're so fortunate, especially folks in the Northern Region chapter have a variety of clinics to attend. But you go to clinic maybe every 3 months, or if you miss a clinic, maybe every 6 months. The reality is this ALS journey happens at home. You're at home on a day-to-day basis. And as we have learned, particularly this year, a lot can happen between clinic visits. So it's important for you to communicate with that home care company, whether it's your durable medical equipment company, your home care company, with regard to the equipment you're using at home, whether it's mobility, communication, nutrition, or respiratory equipment, and really communicate how that's working for you at home with your clinic team so that adaptations and augmentations can be made as needed. You can see here, really communication is key from your home care company to your clinic, and from your clinic to your home care company. And you probably have a variety of home care and DME companies that you're able to visit as well today. What about the emergency department? Sometimes people with ALS end up having to go to the emergency room due to complications associated with ALS or due to other complications. People can still have a gallbladder attack. People can still have an injury where they may need to go to the emergency room. What's important here, I think, for both those living with ALS, diagnosed with ALS, and their caregivers, is to be proactive about making sure you're prepared for any emergency department visit. Remember, positioning is very important. It's so much easier to take a breath when you're sitting up And again, to let that emergency department staff know you need to sit up in order to ventilate effectively. What about respiratory evaluation? Remember, we talked about oxygenation ventilation. So often, especially when we watch medical shows on TV, we see people running into the ER and putting oxygen on right away. But it's important to remember that while we don't want to avoid having appropriate oxygenation, ventilation is so important. We want to make sure that if anyone with ALS is provided oxygen, they also have ventilation equipment nearby, because most often the issue is their ability to ventilate, to get the volume of air in versus the oxygenation. So that may be important for you to share with the emergency department team. Communication is so important. Looking here, you can see that two-way communication between that valuable caregiver and the emergency department team. And it's always good to have a rapid access communication available to you, even if you're fortunate enough to utilize some of the great technology these days, where you have an eye gaze system or you have a speech generating capability on your laptop or your iPad. It's always good to have a paper letterboard available so that you can rapidly access this communication simply by pointing or looking at this communication, especially if you're leaving your home quickly and going into an emergency department. Multidisciplinary care is so important. It really comes together to address your total quality of life. And we know that hospice is the most frequent chosen care plan of people with ALS. Let's also remember that so often people hear the H word and they associate that with the end of a journey. But I would venture to say that we may want to consider looking at hospice not so much as the end of our journey, but really hospice care, the care that we're going to be receiving, that we choose to receive as our journey unfolds. Oftentimes hospice services, and they have a plethora of services available, are underused. I would urge you to investigate the palliative and hospice services that are available in your community ahead of time, so you know what services are available to you and how they can address your quality of life. Again, I want to share that the use of respiratory support devices will not stop the progression of disease. And I think that's important because some folks misunderstand that the use of a non-invasive ventilator or a bi-level ventilator is not allowed in palliative or hospice care. And I wanted to reiterate that the use of these devices will not stop the progression of the disease or change the course of the disease. It will simply provide you with the adequate ventilation you need as your disease progresses. Then that can result in extending your life. Wrapping up, I know we focused on respiratory challenges associated with ALS. We looked at some of the specific respiratory challenges, some of the other challenges people commonly have with ALS, and how there is an overlap with that. It's important to really connect with your multidisciplinary team. Some people bring up respiratory challenges with their physical therapist or their nutritionist, and that's appropriate because the value of the multidisciplinary team is we're working together for you. Investigate all the treatments and the symptom management options, and investigate them ahead of time so that you can determine what kind of care plan you want to develop. And remember, it's okay to change your mind. Go ahead and develop the care plan that you think is going to best fit your needs. And then remember, as your journey unfolds, you have the option to change your mind and edit that. And then remember, it's up to you. Select the appropriate supports that are going to drive your quality of life. What's important to you? Your clinic team, the treatment that you select, and your quality of life are all in your corner. So thank you so much for carving time out to join me today. I wish you well as the fall and autumn season unfolds in that beautiful part of the country that you're in, beautiful colors. And please don't hesitate to connect with the local chapter or your clinic if you have any additional questions regarding respiratory challenges or potential supports for your respiratory and ventilation systems. Amber, are we available to answer some questions?
Yes, it's Lori. I'm up here with you as Amber prepares for our last piece. We do have one question already, Cynthia, from David. David is asking, can you describe the relationship or difference between FEV and FVC?
Sure. The FVC is the forced vital capacity, and the S, like Sam, VC is the slow vital capacity. Most often we hear the FVC, F like Frank, which is forced. So we take in a deep breath and then blow out hard and fast. One of the challenges with that, especially with people with ALS, is as our throat muscles become weakened, sometimes those throat muscles close off as we're blowing out fast and cause an obstruction, so we don't get a true value of that volume. Oftentimes, your clinic will ask you to do an FVC of forced vital capacity, and then they'll say, let's do that again, but this time blow out slow. And what that does is that enables people that have some of those weak throat muscles to blow out slower and avoid some of the obstruction. I can tell you that almost all of the research that's associated with the clinical trials, almost all of them include an FVC, but many of them are also including the S or the slow vital capacity as well, because we want to make sure that that volume of air that we're measuring is accurate.
That's really helpful. Thank you. And David also says wonderful, informative presentation. Thank you so much. I can't help but think, what a wealth of information is in this presentation. And I just want to remind folks, this is being recorded and you can watch it a number of times and then take the information and the questions you have and certainly bring them to your clinic team, your pulmonologist, your neurologist, or your primary care doctor. So might feel like a lot, but as you work through it, you and your team can figure out what's going to make sense for you. I'm not seeing any more questions. So I think, Cynthia, I just want to say thank you. I'm sorry that we didn't get to bring you up for the foliage this year. I know you love it, but hopefully you'll come back again and visit when COVID is gone away. And thank you again for such a great presentation for our folks in Northern New England.
Thanks so much. A safe weekend to everyone.
Thank you. You as well.